Hello, my name is Dr. Paul Richardson and I'm the Clinical Director of the Jerome Lipper Multiple Myeloma Center at Dana-Farber Cancer Institute in Boston. Today I wanted to talk to you from this year's ASCO meeting about where our thoughts are going in terms of optimal upfront treatment strategies for patients with newly diagnosed myeloma. Perhaps we'll start first with the transplant-eligible population. These tend to be younger patients with excellent overall functional status and the absence of serious end organ problems that might make transplant potentially hazardous. In that context, 3-drug regimens really do appear to have established themselves as the gold standard. In that regard, in Europe, bortezomib, thalidomide, and dexamethasone is widely used. So is cyclophosphamide, bortezomib, and dexamethasone as well. And in the United States, we are fortunate enough to have access to a broad range of 3-drug options, including lenalidomide, bortezomib, and dexamethasone, so-called RVD, and a very exciting new arrival, so-called CRD, or carfilzomib, lenalidomide, and dexamethasone, which has been shown to have excellent activity and also very favorable tolerability, certainly in terms of neurotoxicity. Now, in the context of both of these 3-drug regimens, the important side effects to be aware of with RVD include neurotoxicity, but with the use of subcutaneous bortezomib, that can be substantially reduced. It's important to note with carfilzomib that that drug is generally very well tolerated, but there is a small number of patients who may be affected by cardiovascular events, and these need to be carefully watched for, together with careful attention to renal function, blood pressure, and pulmonary function as well. But as I say, generally well tolerated and exquisitely active. So I think in the newly diagnosed population of transplant-eligible patients, we're seeing 3-drug regimens dominate, and we're seeing those be used to optimal response and then transplant pursued subsequently. Obviously, in the non-transplant eligible and older population, we have a number of choices. Certainly at our own center, we like to use the combination of lenalidomide, bortezomib, and dexamethasone, but we call it RVD Light. This work actually has been led by my colleague Dr. Nupa Rajay, and what we're doing in this context is exploring weekly bortezomib given subcutaneously with lower doses of lenalidomide and dexamethasone in the older population, with patients over the age of 75 in particular of interest, and also other patients who may not be transplant eligible for various reasons. And we're finding so far that this particular combination is very well tolerated and very active, although it remains early days in our current prospective study. By the same token, other approaches in older patients include 2-drug regimens, such as, for example, lenalidomide and dexamethasone, lowering the doses appropriately. But there's some very interesting and exciting studies looking at combinations of, for example, lenalidomide and dexamethasone with elotuzumab that are currently under study that may hold great promise in the future with a relatively non-toxic but highly active approach going forward. Certainly also lower dose stress strategies with carfilzomib, lenalidomide, and dexamethasone are also being explored in older populations. And again, similar to what's seen in the younger patients, the combination is very active with very favorable tolerability seen to date. Overall then, I think that the differences between older and younger patients actually are becoming less pronounced as we basically use the same constructs of combination therapies in both patient groups. But critically, the importance of managing side effects using weekly bortezomib, for example, subcutaneously, lowering doses of steroids in particular, moderating doses of immunomodulators if necessary, and integrating other drugs ranging from conventional cytotoxic therapeutics to more novel agents such as monoclonal antibodies are becoming very exciting new trends going forward. I would just conclude by saying that in the realm of transplantation, we are seeing data from Europe that suggests, certainly in 2 studies led by Dr. Antonio Palumbo, that progression-free survival overall may be enhanced by transplant after 2-drug initial regimens. But what we don't know is the impact of proteasome inhibition in these studies because they were not permitted. Thus, current ongoing trials, of which one is the IFM Dana-Farber study of RVD with or without early transplant, are priorities in our clinical research efforts to best define who benefits from what, when.